بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, we are now discussing the issue of spinal trauma in the series of spinal imaging. And as you all know that we have three types of spinal fractures that are the uh, burst fracture or the comminuted fracture of the vertebral body, the wedge compression fracture, and the teardrop fracture. As you can see here, this is the plain X-ray of the lumbar spine showing an example for compression fracture of the L1 vertebral body with anterior wedging. And this is an example of burst or comminution fracture where you got multiple vertebral fragments. The third type is the teardrop fracture, or what's known as flexion distraction fracture. And this is one of the severe injuries of the cervical spine, especially the flexion type. This occurs in the commonly at C5-6 level, and it involves the presence of a sagittal fracture through the vertebral body and a fracture of the anteroinferior aspect of the vertebral body, which is known as the teardrop, and hence the name. There is also anterior wedging of the vertebral body with narrowing of the related disc space. This fracture is, as I have said, is very severe, and it may result in dislocation of the facet joints, as I will explain after that. And you all know that we have the three columns in the of the vertebral column or vertebral alignment, and they are divided into three parts. The anterior column, which comprises the anterior longitudinal ligament, the anterior aspect of the annulus fibrosus of each disc, and the anterior two-thirds of the vertebral body. Then the middle column, which represents the posterior longitudinal ligament, the posterior part of the annulus fibrosus, as well as the posterior third of the vertebral body. And the posterior column represents the posterior ligaments, the interspinous ligaments, as well as the posterior elements, including the pedicles, the laminae, as well as the spinous processes. Then, according to affection of any of these columns, the fractures are classified into stable and unstable fractures. The stable fractures are usually affecting only the anterior column of the vertebrae, and they do not cause spinal deformity and do not cause neurological deficits. And if you see a fracture that affects the anterior two-thirds of the vertebral body, it may affect the anterior longitudinal ligament, and the posterior column, the middle column is intact, as well as the posterior column is also intact. You can assume that this fracture is stable, but you should realize also that the clinical symptoms of the patient shows no evidence of neurological deficit. Then we have three types of imaging modalities for diagnosis of the spinal fractures. The first one is the X-rays, and the main values of the X-rays are to detect the site of the fracture, the type of the fracture, and may give you an idea about the stability of the fracture. And here you can see that there is a compression fracture of one of the vertebral bodies with anterior wedging. The posterior or the posterior aspect of the vertebra is more or less intact, hence the middle column is preserved. It's only affecting the anterior column. Then CT is relatively more informative than the plain X-rays, especially if you have the reconstructed images, particularly in the sagittal plane. Then CT will show intraspinal bone fragments that cannot be usually cannot be seen by the plain X-ray. It can also detect the sagittally oriented fractures, which are the one which represent one of the findings that should be identified in each case. Then fracture of the neural elements is also important to be mentioned in the report, and in some patients a CT can show paravertebral or intraspinal hemorrhage. And this is an example of a comminuted fracture of the vertebral body with a sagittally oriented fracture, which is the fracture line bisecting the vertebral body from anterior to posterior or from posterior to anterior. And also it can show this fracture of the right lamina. The sagittal reconstructed image shows comminution of the vertebral body with posterior subluxation encroaching on the spinal canal, meaning that there is disruption of the anterior and middle columns. And this is an example of a fracture affecting all columns of the spine by CT and by MRI. By CT, they can see the comminution of the vertebra, and you see the sagittally oriented fracture, and you see a fracture of the neural elements, and also you can detect the large intraspinal displaced bone fragments. And in the MRI, the fracture affects this vertebral body, which is posteriorly subluxated, encroaching on the spinal canal and compressing the distal part of the spinal cord. And you can see that there is disruption of all major spinal ligaments, including the anterior longitudinal ligament, the posterior longitudinal ligament, the ligamenta flava, the intraspinous ligaments, the ligaments between the spinous processes and the supraspinous ligaments. The ligaments are running posterior to the or connecting the spinous processes. There also disruption of the articular processes or articular facets on both sides. And here you can see the vertebra, the affected vertebra showed bone marrow edema, low signal in the T1 and high signal in the T2. And you can easily appreciate the presence of this big bone fragment inside the spinal canal with disruption of the posterior ligaments and the neural arches as well. And in this type of the fracture, you can see compression, fracture of this is L5, L4, L3, L2, and this is L1 vertebral body with depression of the superior and inferior end blades. There is mild posterior subluxation of the vertebral body encroaching on the spinal canal. The axial image shows comminution of the vertebral body with no evidence of bone fragments inside the spinal canal. Also in this patient you can see a first degree spondylolisthesis of L4 over L5 with vacuum phenomena in the intervertebral disc space. This is the axial image of a patient with spinal fracture showing sagittally oriented fracture in the vertebral body, fracture of the left lamina, multiple comminuted bone fragments inside the spinal canal. Then the 3D and 2D reconstructed images can show the degree of fracture, the posterior displacement of the bone fragments. And in my opinion, the 3D images of the spine are not helpful in the diagnosis compared to the 2D images, particularly the sagittal one. Then MRI has an advantage over CT and the plain X-rays in the fact that it can show the spinal cord pathology. Then MRI can detect the site, the type, and the stability of the fracture. It can also show the degree of neural canal compromise, and very importantly, it can show the possible or the suspected cord injuries together with the sensitivity of bone marrow, the sensitivity of MRI to detect bone marrow changes, the detection of intraspinal and paraspinal hemorrhage. Then this is the CT scan of the patient with traumatic spondylolisthesis of this is 456 of C6 over C7 with the deformity of the spinal canal. Then by MRI you can appreciate the degree of cord injury here. You see this is the cervical spinal cord, which has almost let's say subtotally transected here at the level of the fracture. Then this is the severe type of dorsal spine fracture with fourth degree spondylolisthesis of one of the dorsal vertebrae, which has became in front of the lower one. You see the marked deformity of the spinal canal with diffuse high signal intensity of the cord in T2 weighted images denoting the presence of cord edema. These are the possible lesions that can be seen in the spinal cord in cases of spinal trauma. Of course, edema is very common. Intramedullary hemorrhage, laceration of the spinal cord, complete transection of the cord, and the development of intramedullary serings and cord atrophy are usually considered late sequelae of trauma. Then this is a hyperflexion injury with compression fracture of the first dorsal vertebrae. And you can see there is a subtotal compression collapse of D1 vertebral body, which is posteriorly subluxated, encroaching on the spinal canal. And this is T2 and this is T1 weighted image. You can see that the cord is a little bit compressed, but you can appreciate that the cord parenchyma is of normal signal intensity. And here is a fracture at the level of this is L5, L4, L3, and L2. The fracture is in the form of compression with some comminution of the vertebral body, depression of the superior end plate, posterior subluxation or retropulsed bone fragment encroaching on the spinal canal. Then you may need the axial images to show the exact encroachment on the cord and on the spinal canal to see the retropulsed bone fragments to assess for the possibility of the fractures of the neural elements like the pedicle, the laminae, the spinous processes, and the transverse processes as well. The coronal images are helpful in the detection mainly of paraspinal pathology, especially in the paravertebral muscles, considering the presence of edema or hemorrhage. And this is a fracture at C5 level. You can see that there is traumatic spondylolisthesis of C4 over C5. C5 has been subtotally collapsed. It is seen encroaching on the spinal canal. The cord is compressed and it shows faint increased parenchymal signal in this T2 weighted image, denoting the presence of some cord edema. And this is the traumatic spondylolisthesis of C2, 3, 4, 5 of C5 over C6. You can see that there is deformity of the spinal canal with faint intramedullary area of high signal in T2 weighted images, which is not appreciated in T1 weighted images, denoting the presence of cord edema. and this is the opposite of the previous case. You have here traumatic retrolysis of C5. This is 2, 3, 4, and 5. C5 vertebral body has been posteriorly displaced, encroaching on the spinal canal. The body is compressed, anteriorly wedged, and posteriorly subluxated, compressing the cord, which presents diffuse area of increased T2 signal, which is not appreciated in the T1 weighted image, denoting the presence of cord edema. And sometimes in patients with trauma to the spine, you may not see fractures, but you can appreciate some soft tissue injuries, particularly injuries of the spinal cord. And here you can see a focal area of bright signal intramedullary in a patient with trauma to the cervical spine. There were no fracture lines here, but there is only cord edema, which is one of the post-traumatic complications. Then hemorrhage inside of the spinal cord may be the sequelae of trauma. As you know, that hemorrhage is usually of bright signal in the T1 and bright signal in the T2, representing the subacute blood elements. And sometimes you can see hemorrhage in the acute phase or maybe in the chronic phase, but commonly you see hemorrhage in the subacute phase where the hematoma is bright in the T1 and also bright in the T2 weighted image. These are some of the causes that may result in intramedullary hemorrhage. Actually, the trauma is one of the major or common causes. Then the presence of an arteriovenous malformation that cause some bleeding, clotting disorders, inflammatory myelitis. You remember the acute demyelinating encephalomyelitis. Some of the spinal cord tumors may bleed. Abscesses and the syringomyelia may show some internal hemorrhage. Then this is a wedge compression fracture of L1. This is L5, L4, L3, L2, and L1. There is anterior wedging of the vertebral body. The posterior border of the vertebra is intact. There is no encroachment on the spinal canal. In absence of any significant neurological deficits, you can assume that this fracture is stable. And this is also an example of a stable fracture of L3 vertebral body. You see depression of the superior end plate, wedging of the anterior aspect of the vertebra, but the posterior aspect of the vertebra is intact. There is no encroachment on the spinal canal. The vertebral body shows diffuse or heterogeneous low signal in the T1 and high signal in the T2, representing bone marrow edema. And this arrow points to this fracture line, which is clearly seen also in the corresponding axial CT image. And this is a compression wedge fracture of C4, which is posteriorly subluxated. You see the fracture line, you see the anterior wedging, and the posterior border of the vertebra is encroaching on the spinal canal and also commonly compressing the spinal cord. Then cord edema will appear of bright signal in the T2 and intermediate or low signal in the T1, while hemorrhage will appear if it is in the subacute phase of bright signal in both path sequences. If hemorrhage is in the acute phase, you will see low signal in the T2 weighted images and also intermediate signal in the T1, and you may not appreciate this acute blood in the T1 weighted images. But because of the presence of cord edema, which is this bright diffuse brightness in the spinal cord, you can appreciate these black dots, which represent the acute blood, which represents the deoxyhemoglobin. Then traumatic spondylolisthesis is the kind of trauma that may result in fractures of the pars interarticularis, traumatic fracture of the pars interarticularis, and this may lead to displacement of the vertebral body. Then you have spondylolysis. If no displacement, like in this case, and this is known as spondylolysis. This is a severe fracture with combination and traumatic and anthrolysis of L4 over L5. There is almost obliteration of the spinal canal by bone fragments. There is comminution of the vertebral bodies, and actually some of the fractures of the posterior neural arches. This is an extensive unstable fracture of the lumbar spine. You see the fracture in the brain X-ray, and this is MRI T1 and MRI T2 weighted image, and you can appreciate the degree of bone comminution, bone marrow edema, soft tissue edema, and hemorrhage in the vicinity of the fracture, with obliteration of the spinal canal by bone fragments and hemorrhage as well. And this is a severe unstable fracture of the mid-dorsal vertebrae. There is posterior displacement or retrolysis of this vertebral body. There is complete disruption of the spinal canal and possibly complete transection of the spinal cord. And one of the complications of trauma is the post-traumatic disc herniation. And sometimes with flexion injuries, you got spondylolysis of one of the vertebral bodies over the lower one, and this may result in disruption or rupture of the annulus fibrosus, resulting in herniation of the nucleus outside the confinement of the annulus, and this will appear in the images as acute post-traumatic disc herniation. This is what we call hyperextension injury with teardrop fracture, which is completely different from the flexion distraction teardrop fracture. This type of fracture is not as severe as the flexion teardrop because the vertebral body is not displaced and is not collapsed. And in this fracture, where hyperextension of the neck is present, then you got only separation of the inferior corner, anterior-inferior corner of the vertebra, and the rest of the vertebral body is intact. The vertebral body is not displaced, it is not encroaching on the spinal canal. So we have two types of teardrop fractures: the flexion one, which is very severe, the extension one, which is not severe like the flexion one. Then there are special types of spinal fractures, and we would like to say some words about Jefferson fracture, hangman fracture, odontite fractures, and the facet dislocations. Starting by Jefferson fracture, which is an uncommon, unstable injury of the cervical vertebra number 1. And this fracture will result from axial loading impact through the occipital condyles to the lateral masses of C1, and this is one of the best examples for a common cause of this fracture, which is diving in a shallow water. Then the fracture is not normally associated with neurological deficits, and spinal cord injury may occur if there is retropulsed bone fragments inside the spinal canal. And then you can see here that there are multiple fractures affecting the arches of C1. And this is an example. You cannot appreciate the fracture in the plain films, but you can see it very good by MRI. This is a fracture in the anterior arch, and this is a fracture in the posterior arch. Also, there is this is a Jefferson fracture affecting C1 vertebral body with 2 fractures anteriorly and 2 fractures posteriorly. This fracture may be associated with many other injuries, like injuries of other cervical vertebrae, as seen in 50% of the cases, fractures of C2 vertebral body seen in 33% of cases, concomitant or concurrent head injury in about 1/4 to 1/2 of the cases, injury of the vertebral artery, because you see the neural the foramina transversaria where the vertebral artery is crossing through it, and extracranial nerve injuries may also be seen. Then we came to the hangman fracture, which is by definition is a traumatic spondylolysis of the axis, and this will usually result from hyperextension injury leading to bilateral fracture of the pars interarticularis of C2. And we have three types of hangman fracture depending on the state of the disc space between C2 and C3. Then if there is fracture of the pars interarticularis bilaterally and the disc space is preserved and the vertebra is not displaced, we call this hangman type 1 fracture. But if there is disruption of C2-3 disc space, like in this case, and we call this type 2 hangman fracture. But if there is dislocation of the vertebral body anteriorly representing traumatic spondylolysis of C2 over T3, then we call this type 3 hangman fracture. And this is the hangman fracture of the type 3 appearance, and you see there is fracture of the pars interarticularis of C2 vertebral body. The vertebral body has been displaced anteriorly relative to T3, representing traumatic spondylolysis. And this is the appearance of type 1 hangman fracture by the plain X-rays and by CT. You can see the fracture of the pars interarticularis bilaterally, but the disc space is maintained and there is no displacement of the vertebral body relative to C3 level. Also, you can see the fracture of the pars interarticularis more clearly by CT scan, as you can see in this particular case of hangman fracture. Then we came to the fractures of the odontoid process. We have three types of odontoid fractures. If the fracture involves only the tip of the odontoid, then we have type 1. If it involves the base, then we have type 2. If it involves the base together with part of C2 vertebral body, then we have type 3. And this is type 2 odontoid fracture in the sagittal reconstructed image by CT. There is fracture of the base of the odontoid process. And this is type 3. There is fracture of the base of the odontoid process together with part of the C2 vertebral body. Then we came to an important issue, which is the facet locking. Facet locking means that there is abnormal relation between the articular facets in the cervical spine. And whenever there is flexion injury with traumatic spondylolysis, and you can see in this X-ray the relation of the facets of the vertebra above to the facet of the vertebra below. The articular facet of the vertebra above is posterior to the articular facet of the vertebra below. But if this vertebra has been displaced anteriorly, then the articular facet has the chance to flip anterior to the inferior facet. And at that time, we call this facet locking, where instead of being posterior, then it will become anterior to the facet of the lower vertebra. And in the axial image, you can see the facet joint, which is almost similar to a sandwich of hamburger. And this, the articular facet of C5, and this is the articular facet of C4. And you know, the articular facet of the vertebra above should be posterior to the articular facet of the vertebra below. This is the normal relation. Then, if there is facet locking, this is the normal appearance of the facet in the axial image. But if there is facet locking, then you will see that the articular facet, which should be here, will become posterior to the articular facet of the upper vertebra. Then you got the reverse of the hamburger sandwich, like this one. Then you see, in the axial image, instead of being here, it is now there. Then you got bilateral articular or bilateral facet locking. This facet locking can occur unilateral or may occur bilateral, as you can see here in this case. Then in the plain X-ray, you can appreciate this appearance of facet locking. This is the diagram showing the normal relation between the superior facet and the inferior facet. The superior facet should be posterior to the inferior one, but this is abnormal relation because the superior facet now is anterior to the inferior facet, and this is what we call facet locking, which is clearly demonstrated here. This is the normal relation and this is the abnormal relation. In the axial image, you can see that the right facet is good with normal relation, and the left facet is not good with abnormal relation, and this is unilateral facet locking on the left side. Then if you look carefully here, there is traumatic spondylolisthesis of C6 over C7, and if you look to the off sagittal images, and you can see that the above facets have normal relation to each other, while at the level of the fracture, the articular facet is now anterior to the inferior articular facet. Then there is facet locking here, and this can be appreciated in the sagittal as well as in the axial images. This is the normal relation of the articular facets bilaterally, and this is facet locking on the right side with normal appearance of the facet on the left side. Then sometimes by trauma, you got only widening of the facet joint with maintained relation of the articular facets, and this is diagnosed as facet joint subluxation. And one of the fractures that are known in the lumbar spine is what we call chance fracture. This is a pure bone injury extending from posterior to anterior. It affects the posterior neural elements, then going through the vertebral body. The injury passes through the spinous process, the pedicle, then the vertebral body. And this is a flexion distraction fracture related usually to the seat belt of the car, for example, or anywhere. Then the fracture can be appreciated very well in the sagittal reconstructed images. So whenever you see the fracture line passing through the vertebral body and the posterior neural elements, then you assume that this is a chance fracture. And this is a good example for a chance fracture of one of the lumbar vertebral bodies passing through the posterior arch. And this is also a chance fracture, and this was the type of injury. And here you can see some anterior wedging of the vertebral body and the fracture line going through the vertebra, as well as continuing posteriorly through the neural elements. Then this is the fracture after internal fixation with transpedicular screws and metallic rods. A chance fracture is usually appreciated by CT, but can be also seen by MRI. And you see this is T1 and this is T2. One of the lower dorsal vertebrae is affected, And if you look carefully, you can see that the fracture is extending posteriorly through the neural elements. And this is the appearance of the fracture by CT, and you can see some of the retropulsed bone fragments encroaching on the spinal canal. One of the fractures also of the spine is the Clay-Schlover fracture, which means fractures of the spinous processes. It can occur at a single level or may affect multiple levels. And here you can see in this sagittal reconstructed image of the cervical spine multiple fractures of the spinous processes of the lower cervical and upper dorsal vertebrae. الحمد لله رب العالمين والسلام على أشرف المرسلين والسلام عليكم ورحمة الله. Thank you very much.